All right. Hi, everyone. I'm Brianna Yoakum. I'm the Director of Accreditation with the Washington Alliance for Quality Recovery Residences. Today, our presentation is going to be on medications for opioid use disorder and patient rights within recovery residences. So I've been really looking forward to having Jessica and Lauren present this information with us today. I am also joined by Sarah Carr. She's our Assistant of Accreditation. She'll just be helping let people in the back. So we will have this presentation recorded and available on our website. So if you get a lot out of this and you want to share it with others, feel free to direct them to that recording. We will also have the slides available. And for everyone who has registered, we'll just send that out probably within 4 or 5 days after the webinar. So with that, I'll go ahead and hand it over to Jessica Blose and Lauren Kula and get started. Thanks so much.
Hi there, good
Thank you so much.
Oh, go ahead, Lauren.
Oh, I just was just going to say that I am going to get the slides up. So just give me 1 second. Okay. Yeah. Should be able to see them now.
Yes, we can see them. Yeah, hi everybody. I'm Jessica Blose. I work at the Washington State Healthcare Authority, and I'm very lucky to be our state's opioid treatment authority. And what that is it's just a really big title, meaning I get to help really with all things related to opioid treatment here in the state of Washington with myself and my team. And I'll introduce you all to Lauren, who will be starting off the presentation today.
Yes. Hi, good morning, everyone. My name is Lauren Kula, and I am a substance use disorder professional and a social worker. I work with Jessica on her team. I'm the Opioid Treatment Quality Improvement Program Manager. And so I really get to help out in all ways for the opioid treatment programs, but mainly specific to patient rights and patient discrimination. And I just also wanted to say a big thank you to all of you for allowing us to present today. I want to express just a lot of gratitude for allowing us to talk about MOUD and for you being open to this topic. So thanks again, and we will start in. The agenda today is going to focus on what are medications for opioid use disorder. So just a general broad overview. We'll talk a little bit about MOUD and stigma, and then we'll wrap it up with patient rights and recovery residences and MOUD specifically. We are also very open to having this be a discussion type of a presentation. So very much please feel free to raise your hand, put stuff in the chat, interrupt, it's not an interruption, it's just a question. So please, at any time, if you have a question, feel free to just, chime in and ask away. You don't have to wait till the end, but I will ask if there's any questions anyways. All right, starting right in with medications for opioid use disorder. There are 3 medications for opioid use disorder that are FDA approved, and that is methadone, buprenorphine products like Suboxone or Sublocade, and naltrexone. And we're going to be using the term MOUD, or medications for opioid use disorder, instead of MAT. And that is really to just reduce overall stigma of the medications for substance use disorders in general. MAT sort of implies that medications should be temporary or that they have to be connected with supplemental treatment like counseling in order to be used. But then MOUD really aligns with how other psychiatric medications are understood. So I always tend to give the example around medications for opioid use disorder are similar to medications for anxiety or medications for depression, where it's really about brain stabilization and not like something that needs to be used for a set amount of time or in conjunction with some type of treatment. Although, medications for all psychiatric and behavioral health disorders are encouraged to use supplemental counseling and therapy as long as it aligns with the patient preference. So that's just kind of the language that we'll be using. This is actually taken from a patient decision-making aid from UW ADAI, and I will throw that in the chat down the road. I've got it linked to the slides, but I will also put it in the chat a little bit later. And this really gives an overview of all 3 medications for opioid use disorder. Really laid out to help the patient and the provider make the best decision for themselves. But also just, it's great for presentations too, conveniently, to tell everybody about what these medications are, what the differences and similarities are. So just running through them pretty quickly, because I'm sure that this is a review for all of you. Methadone is a full opioid agonist medication. So the more that a person takes, the more that you tend to feel the effects. It manages cravings and withdrawal symptoms by binding to the opioid receptors in the brain. It does lower the risk of death by 50%. Lasts about 24 hours in the body and is taken by mouth. It's usually in the form of a liquid. And where do you get it? So the thing about methadone is that for an opioid use disorder, it is only available at opioid treatment programs. And a little bit later down in this presentation, I will have a map of where all those opioid treatment programs are located throughout the state. And I will throw in the chat our opioid treatment program guide that also lists all of the opioid treatment programs that we have in the state right now. There are 40 treatment programs in the state, which is a lot, but there's also a lot of expansion happening throughout the state right now, including brick and mortar sites, but also mobile medication units. Mobile medication units are sort of like RV type vehicles that travel from the home opioid treatment program to a set location, usually one location, but sometimes it's 2 locations during the day. And they help to serve people in more rural communities or even like institutions like jails or prisons, so that folks can get their medication and not have to drive sometimes pretty long distances in order to receive their methadone medication. An example that I have is there's a methadone medication unit, and it travels from the home opioid treatment program in Spokane, about 45 minutes north to the Deer Park area. It just really helps create more access to specifically methadone and all 3 medications for opioid use disorder for folks that may not have that easier access in a more urban type setting. Another thing about opioid treatment programs is dosing happens, historically it's happened, 6 days a week. Folks have to go to the opioid treatment program every day in order to receive their dose. But, great news is that the federal rules have recently changed, and they also changed through the COVID pandemic. So during the COVID pandemic, when we didn't want thousands of folks going to a set location, so that for social distancing purposes, there were more take-home medication doses allowed and available for patients. So that means they could go to the treatment program however, like once or twice a week, and get a set number of take-home doses to be able to take their medication at home instead of going to the program every day. And that has proven that through the COVID pandemic that there weren't increased deaths from like overdoses from methadone specifically, or increased diversion for like people weren't giving their methadone away. They were using it, they were taking it as they needed to for their own specific opioid use disorder. So the federal rules have since made those COVID pandemic rules set so that folks they don't need to go to an opioid treatment program consistently, like every day, 6 days a week. If they are appropriate and they are allowed the medical director to have medications taken home at an earlier rate instead of waiting like potentially, months, even like years in the past. It could happen within maybe a month that they would be allowed to take home more medications, which is great news. So this is a really wonderful thing for patient access. And I think it really also helps decrease this potentially like the stigmatization of opioid treatment programs too. Moving on to buprenorphine products. So buprenorphine is a partial agonist medication. So it does have a ceiling effect. So above a certain dose, you won't really receive, there won't be any more effects of the opioid. It manages cravings and withdrawal symptoms by, again, binding to those opioid receptors. It lowers the risk of overdose by 50%. There's an oral medication that lasts about 24 hours. Then there's also long-acting injectable forms of this medication, and that can be up to lasting up to 28 days. There's also formulations that are like 7 days or 14 days as well. And this, so buprenorphine or Suboxone or Sublocade can actually be prescribed by a medical provider. So you can go to an opioid, it's called an OBOT, an opioid office-based opioid treatment program, or even just your medical provider to get a prescription for buprenorphine products, and you can fill that prescription at a pharmacy. And or with the long-acting injectable medication, you do have to go to a doctor's office and have that administered to you. But these medications are also available at opioid treatment programs. And then finally, naltrexone. Naltrexone is an opioid blocker. It is not an opioid, and so you will not feel any opioid effects. It helps, again, manage cravings. It has not been shown to lower the risk of death, and it's usually an injection for opioid use disorder that lasts about 28 days. It can be prescribed and given at a medical provider or medical facility, and is also available at opioid treatment programs. And then this is just a little visual of how the brain, how the receptors work with each medication. And I will also pause here to see if there's any questions around MOUD in general, or even opioid treatment programs, just to help us kind of get a baseline before we dive in a little bit more.
Now, while we're thinking about any questions, I just want to remind people there's the chat function. You can feel free to add in questions that you might have about individuals taking these 3 medications so we can try and answer them during the presentation. But I am just curious to know, have you already seen folks on these medications coming into your recovery residences? So yeah, anyone be willing to enter something in the chat or come off mute and just let us know if you already had these experiences with all 3 medications that Lauren's been talking about.
Yeah, my name is Brendan, and so I work with clients on Suboxone and methadone, and I was actually just typing up my question. But my main concern really is the stigma that surrounds any medication for opioid use disorder. Even within the recovery community, I've seen people in NA talk negative about it, which kind of turns people off from wanting to get on that medication. Like people that are coming off of heroin, for a long time, that have, they think that they're trading one drug for another, and it's just really frustrating. So I guess kind of my question is, how can we educate people more to break that stigma? Because, I've seen these medications help people reclaim their lives. And, it's like, I kind of look at it like, people that are terminally ill or people that have other diseases, right? They take medication for that, so I kind of look at it like the same way. So yeah, I guess what steps are being taken to kind of educate people and promote awareness about that, I guess.
I feel like we are definitely going to be talking about that in this presentation, Brendan. So we're going to be hang tight for a minute. But yes, that's such a great question. And honestly, also really at the core of what we're here to talk about today with patient rights, right? Because everyone recovery journey could look different. And different things help different people. And that's right where we're all here to support people in their individualized journeys of recovery. There is a question in the chat. I'll put answer to just saying like, what about Subutex? So really Subutex is just one form of a buprenorphine medication. So when we say buprenorphine, it's more like the generic, there's the generic name of drugs. So it's one type of buprenorphine, and it's also the one type where sometimes the medication is combined with naloxone. It's like Suboxone is buprenorphine and naloxone in the same medication, and Subutex is just straight buprenorphine without the naloxone added. So hopefully that will answer. And then it looks like there's another question for later. Lauren is talking about, says, Heather wrote, I am most curious about recourse for when I hear a client state that the housing they were referred to after completing inpatient treatment still will not allow them to take things like methadone for OUD. So yes, we're definitely also going to be talking about that. But I really appreciate this. And again, just like Brendan did, please feel free to come off mute. Please feel free to put things in the chat. And then again, we are going to keep addressing it. I'll turn it back to them.
I'm just glad that that you all are here, and it just sounds like we're all on the same track. So I'm just glad that these questions are already popping up, and we'll address those things. But if there are definitely follow-up questions, feel free to come off mute. And I'm really enjoying the interaction already, so thank you. Okay, so like I mentioned, this is the map that we have for all of the opioid treatment programs in the state so far. Again, we have 40 right now, with more expansion happening. And later down the line, I will put this link in the chat so that you can feel free to have this as a resource and look at it further down the line for your local opioid treatment program. Tons more resources that I will also throw in the chat a little bit later. But again, like the opioid treatment program guide, there's the Washington Recovery Helpline that has the MOUD locator, which is a really great tool. You can plug in even just like your zip code, your city, and see a list of all of the locations that have MOUD available in that area. We have a few HCA specific websites that can be utilized for just more information around MOUD, opioid treatment programs, and general opioid use disorder. And then there's also that MOUD brochure, that decision-making aid from UW ADAI that I mentioned earlier and that I had on one of the slides, that can just be a really great tool, hopefully even to just, sort of decrease that stigma as well. I have two sets of slides regarding MOUD and stigma about like myths and truths. And I got this from, I've got the link down at the bottom, but this is just a really great, like very small fact sheet about just sort of those myths that were already brought up. So I just wanted to go through the 6 of these. There's 3 more on another slide, but these are things that come up constantly around just MOUD and just the stigma around it. So the first one, already mentioned today, is MOUD just trades one addiction for another. And, you know, a lot of folks are, you know, continue to say that, like Brendan mentioned, like that's been heard like in NA communities, and it really, I think, you know, something that is that I say all the time is to equate it with balancing the brain, with stabilization. So we're really, you know, when a person uses substances, their brain chemistry is affected, right? And there's no longer that stabilization, that homeostasis in the brain. And when a person, you know, decides that they are ready for recovery, there's also those post-acute withdrawal symptoms that take sometimes even years for your brain to really try to like level out to a place where recovery can be possible. And medications really just help assist that. I also say it's really about similar to medications for other behavioral health conditions like depression or chronic anxiety, where somebody just needs that brain stabilization, that chemical imbalance is happening. So those medications really help to stabilize the brain so that they can go and live a life of a beautiful recovery. Another one is MOUD is only for the short term. And this could be true, could not be true, right? Like it's not only for the short term. It could be for a short amount of time. It could be for a long amount of time. It really just depends on the patient and their provider to talk about what is working for them. And you know, if the patient decides like, hey, this is working and I am really enjoying this stabilization and this balance, and I would like to continue to be on it. Great. We love that. If the person is like, hey, this is not working for me anymore, and I would like to see if I can be tapered off of it and try without medication. Okay, like the provider and the patient can discuss those treatment options and make the best decision for themselves. But it's really about individualized treatment. It is about you know, using it as long as it works for the patient. This next one is, you know, somebody is not severe enough to have medication as an option for opioid use disorder. And that's, you know, that is again for the patient to decide. You know, that patient decision-making aid that I keep going back to is a great way for the patient to try to make that decision for themselves with their provider. A person that has an opioid use disorder of moderate or severe can, you know, get the medication for opioid use disorder. And opioid use disorder is an evidence-based treatment, and it is the gold standard for opioid use disorder. So, you know, not severe enough, there's no, you know, real requirement around that piece. MOUD increases the risk for overdose, and that is completely untrue, right? We talked about how MOUD actually reduces the risk of overdose up to 50%. And we all know that, you know, if somebody goes through a period of withdrawal after using and they go right back to using, potentially they use like the same amount that they were using, that could actually result in an overdose. And if a person is protected with the medications for opioid use disorder, you know, their cravings are decreased, the withdrawal symptoms are decreased, their brain is stabilized, and they may not, you know, even end up going back to using an opioid because they are stabilized. Providing MOUD will only disrupt and hinder a person's recovery process. So no, this is untrue. So medications have been seen to just really assist in the recovery process, improving overall quality of life, again, balancing the brain chemistry to be able to handle stress and to be able to tolerate stress. Above all, MOUD helps reduce mortality through a resident's recovery. And then finally, there isn't any proof that MOUD is better than abstinence. I sort of mentioned this before, but MOUD is an evidence-based treatment option for OUD. It is the gold standard of opioid treatment. And this lists many agencies like with SAMHSA and NIDA and the CDC to say that, medication for opioid use disorder is a benefit for most people that have opioid use disorder.
Yeah.
Did any questions come in around that?
And while people are thinking of questions, I just want to add in a couple of thoughts to say, I know Brendan before was just asking about what can we do to help combat that stigma. One of the things could be to have informational material. It's like some of these myth posters that Lauren is going to be linking to and the materials that will be sent out to you. You could put things around the house. You could put information out. If there are groups in the home, part of what we really would encourage folks to do is to lean into being open to talking about this topic, right? There should not be the stigma as we're talking about these medications. If you're having a group, would it ever be appropriate to have a group that, is talking about this? And what are folks' different experiences with this or with other friends they might have who might be on these medications? We're really trying to just normalize it. And another thing is, say you have residents in the home who maybe do have strong feelings about these medications or concerns or questions. Not talking about it, right, sometimes can make that stigma even more pronounced. But really, a lot of times too, we could treat this medication just like we would any other medication. I know Lauren has used that example of, sometimes for some people who have depression, some people take an antidepressant, some people don't. Some people take one kind of medicine, some people take another. Some people might take it for a little while, some people might take it for the rest of their lives. We wouldn't necessarily talk about if someone's taking insulin for their diabetes or, medications to help with manage their heart disease, which are other chronic relapsing health conditions, just like substance use. So again, I think there is this stigma in part because you're right, folks just don't know what you know until you know. And then another thing is if we lean into kind of just normalizing and talking about it as a normal course of treatment, we'll get into this more later, but introducing it into materials again that might be around the house, the policy and procedures that folks might be aware of when they come into the home, informed consent for coming into the residence. There's just lots of different little ways we can start to talk a little bit more about it and just make sure our policy and procedures and our homes are as inclusive to the wide variety of folks coming in as they can be. Also, I'm not seeing any more questions on this in the chat, but again, want to give another moment if anyone wants to come off mute and say, also, like Brendan, have you experienced, questions, concerns around stigma from residents in the various homes you guys are working in? How big of a problem is this?
I'm Nicole. I work in peer services, so a lot of what we do is about their voice and their choice. So like, it's not necessarily that we would be the ones educating, I guess, our recoveries. If it comes up, we help navigate to where that information is. What are some ways to help do that in a way that I have a lot of coaches that come to me and ask about well, this person is really big on AA or NA, and it's very almost frowned upon in that community. It seems like there's a lot of stigma around it where there's almost this fear about it. What are some ways as a peer support specialist that I can help my coaches navigate through that?
Yeah, some recommendations I might have would be, talking about some of that passive information. Again, could we have more information around the home, like brochures talking about, medications could be an option, like a poster, something, again, talking about it maybe as a group topic, that could be one thing. I think what you're doing already, making sure the staff, like whether it's peers or others in the house, whoever's are the supervisors or, would be providing consultation to a fellow staff, do they feel comfortable and confident in talking about and problem solving? And are things that we could do to just make, again, like the supervisor staff feel more comfortable to talk about these and problem solve. And then you're right. There are absolutely still some self-help groups or AA, NA, whoever, that the culture of that individual group may not embrace necessarily. So in a lot of communities, there might be more than one option for different self-help. Sometimes in a rural area, maybe though that's not always true, but there might be a different AA or NA group or a self-help group that people can go. There's also like online resources, which I know is not a replacement for in-person connection with others, but there are other resources. There are even groups like SOS in certain areas and things that are slightly different than your traditional AA, NA that could be looked at. And then really also, yes, we so support in anything involving with self-help groups that are more formally organized, but also, right, so for someone in recovery, having support from someone in their life, it could be a friend, could be through like sober activities they're getting involved with, like hobbies. There are other areas where you can also look and encourage for support if for some reason they're having a hard time finding that local support with your local NA. But again, also, if that's the case, would group ever be open to, more conversation about this? Also, at the end of the presentation, we're going to be sharing our contact information, and we're kind of fast forwarding real quickly, but we're here to offer help. So we want you all to take our contact information for Lauren and I. And if you're having questions, want help with brainstorming some things, we're happy to be reached out to try and meet with you one-on-one and see if we can help, problem solve. That would make things better for the patients you're working with. So that helps a little bit. But Lauren, do you have any thoughts?
I do not. I think that really covers it.
Also, yeah.
Yeah, thank you. I also just found, I will also send out the in the chat the MOUD and stigma, just this little flyer too, just in case as well. Okay. So I'll just do a quick MOUD recap, and then we're going to go into patient rights. So MOUD, as we talked about, is an individualized recovery process. Decisions around MOUD should be made in a patient-centered and compassionate way. MOUD is evidence-based recovery, and it does not replace one treatment option with another. MOUD can decrease risk of overdose by 50%. And MOUD does not have a time limit and should be used for as long as it is helpful for the patient. Now we're going to jump to patient rights in MOUD. So we're going to go over just like some laws and protections that people with substance use disorders and who are taking MOUD have. So I'm just really going to sort of read off this slide. It's a lot of words, but they are all important words. So I just wanted to make sure that this creates sort of a baseline for what we're talking about with patient rights regarding MOUD. So federal and Washington state law protects individuals taking medications for the treatment of their mental health and substance use disorders against discrimination in a recovery residence environment. So this includes MOUD specifically. And then federal and Washington state law on this topic does include individuals taking medication for the treatment of a behavioral health disorder. This population is considered to have a disability and are therefore protected from discrimination. So if a recovery residence refuses an individual from accessing recovery residence services because they take prescribed medications for behavioral health disorders such as MOUD, or they require an individual to stop taking that medication or change their medication or change the amount of the medication as a condition of attending the recovery residence that they would otherwise be able to access, could be discriminatory and could be violating the following federal and Washington state laws. So the next slide is going to talk about the specific laws around patient rights. So the first one is the Americans with Disabilities Act. So this is the ADA. And the ADA prohibits most recovery residences from removing an individual from a recovery residence, refusing to accept admission to a recovery residence environment, or discriminating in terms and conditions of a recovery residence use against an individual on the basis of disability only. And then there's the Rehabilitation Act. So private service providers that offer recovery residence care but receive like federal grants, contracts, or federal aid must comply with the same non-discrimination requirements conditions noted under the Rehabilitation Act. And then under WLAD, or the Washington Law Against Discrimination, the definition of disability includes substance use disorder. It's, of course, not only recovery residences that must comply with anti-discrimination laws. It's also businesses that are open to the public. That includes all healthcare providers. It's employers with 8 or more employees, most housing providers, public agencies, including court systems, local governments, including their zoning and land use permits policies, and other programs and services involving protected activities. And reasonable accommodations may be required for individuals taking medications for opioid use disorder. So when businesses, employers, housing providers, and any other individuals or entities required to comply with WLAD have noticed that an individual takes MOUD, they may be required to provide reasonable accommodations so that that person is able to take their MOUD of choice. And then so that was, an overview of all of the laws, and it's a lot. So I just wanted to take a pause here, and I'm going to go back to the slide that lists the laws. But are there, any questions around any of these discriminatory, like laws around discrimination for patients?
And while folks are thinking about Lauren's question and just the slides we're presenting, really just want to reinforce that, yes, sometimes it can be challenging to have these conversations and to create that culture of change within our recovery residences, but we're doing it right because what's best for the patients and for their individualized recovery, but we're also doing it because it's what's legally required of us. As Lauren has gone over this material, really, housing providers cannot do the types of things Lauren was mentioning. They cannot say, oh, well, we'll allow you in if you're taking buprenorphine, but if you take methadone, I'm sorry, this is not a good fit. You can't come here. That would be an example of potential discrimination. If someone says, oh, a patient can come here only if they're taking less than 16, milligrams of Suboxone. Like, we can't set limits, right? That's a decision that needs to be made between the patient and their prescribing doctor. And I know there had been a question in the chat before when Heather had asked in the chat, what is their options for recourse when we hear of clients tell us that their housing they were referred to after completing inpatient treatment still won't let them come in if they're taking a medication like methadone? So the reality is there is recourse, because again, as Lauren is saying, there are already both state and federal laws that cover this material. So a couple of things that could be done, on the next few slides, Lauren is going to share a bunch of links to resources where our Attorney General's office even had created a series of flyers and posters that, again, you could print out and hand out to patients. You could put around the facility and around your home, so it's up on the wall and people can see it. If you find out a patient is being given a hard time by a housing place, you could also give this flyer to them, because it provides contact information for a couple of things. Theoretically, anyone can report a house, a recovery residence that might be discriminatory to the Attorney General's office, because there is both consumer and civil rights divisions there that would want to enforce protections under the state version of the ADA WLAD. There's also the Human Rights Commission of Washington State that can receive complaints if patients are being treated less than because they're taking one of these medications. There's also, theoretically, you could go as far as contacting a bunch of other entities too at the federal level. The Department of Justice has been going around and actually taking action against all different types of places, hospitals, skilled nursing facilities, recovery housing that might be discriminating. If you want to talk something much smaller, closer to home, Walker as an organization could be really, really helpful in reaching out to Walker to get resources if you're aware of a housing where there might be an issue, to see if, again, there could be either way they could connect with that house if it's Walker accredited itself, or if it's not part of the Walker network of homes. We could also be connected. Again, our contact information is going to be at the end of the presentation. Our team will cold call any home that we're told about. And we've had so much success because, again, I think a lot of times policy and procedures against this are really rooted in just stigma and lack of understanding about these requirements. And we've actually had a lot of success in getting homes to voluntarily change their policy and procedures and train their staff to do things differently. So we would be willing to reach out. And I know I'm probably just kitchen sinking so many different things. But also, as Lauren covered, in these recovery homes, a lot of times there's some element of state or federal funding that has been given to them in form of grants, right? Different things. So if money has come from the Division of Behavioral Health and Recovery, DBHR, if money has come from Department of Commerce, if there is different funding that these homes are getting, they do have to comply with these rules. And also, theoretically, the recourse could go as far as saying, you might not be able to get money if you want to choose to continue to not allow patients who are on these medications. So there's actually a lot of recourse. In a way, there's almost too many options of recourse. But if you're having any issues, you could always reach out to, I would say, Walker, the Division of Behavioral Health and Recovery, DBHR, or our team, and we can also help you triage and know where to go. And it looks like while I've been talking, there is a couple comments coming through in the chat. Oh, cool. And it looks like Lauren is putting a bunch of the links in. And yeah, again, these are great resources. And the reality is when people are not treated fairly, patients know they're not being treated well. People can tell that, people can feel that. But I think a lot of people don't know that it's not just about feeling bad and feeling shame. It's that it's what's being done to them is illegal. And you're right, there is stigma, but then I really like this quote. Someone once told me, sometimes some of stigma is just a nicer way of saying discrimination, right? And I think a lot of people don't realize that inadvertently, they're actually discriminating against others. But then there's a lot we can do to make sure that our recovery homes are not doing that. And again, we're so proud to be in Washington and all the Walker certified homes and the groundbreaking approach you are all taking on taking on these topics and then making sure MOUD access is available in your houses. So we just want to thank you all for doing this really important work and just acknowledging we're leading the nation in having housing that's as inclusive as possible for folks and supportive of their recovery. So thank you all.
Yes, and I blew up the chat a little bit, so I put a bunch of links in the chat and all of the ones that I previously talked about, but then also some of these additional resources that again will be available after this webinar and you will receive the slides so you can look at these at your leisure. But the one that I do, want to draw attention to is I put it up there, but it's the Know Your Rights flyer that, like Jessica said, could be a really great just flyer to put up in your recovery residence, potentially just so that folks know and understand their own personal rights to their medication for opioid use disorder. And I do believe at this time, I'm going to sort of hand it off to Jessica to talk more specifically about recovery residences and how you all can fold this into your residences.
Yeah,
I'll hand
thank you, everyone. As Lauren has here on this one slide, this whole next part of the conversation, we're so happy to make this part as interactive as you all want to. This really is a call to action because, again, there's always rooms, right, for continual quality improvement when it comes to thinking about what policy and procedures we might be having at our sites and then how we're talking with different staff and residents. So we can go to the next slide and kind of just jump into it. So really, right, some of this might be like very back to basics thing, but we want to make sure that if there are policy and procedures for the organization, you've given some thoughts about how you would address topics related to these medications ahead of time, right? You want to have policy and procedures in place before folks are coming into the residence. Do you have policy and procedures around like how you would allow the medication to be stored in the facility safely? Do you have policy and procedures in place about if there are issues coming up between resident to resident, how that can be mitigated? And then, of course, we want to make sure all of your staff and residents leadership are aware of the policy and procedures and are being trained to them, especially when you're updating things, right? And then, I mentioned this earlier, but we want to make sure that all the staff and residents leadership on site and working with all the residents would know how to seek support within your organization, to ask questions, to seek out consultation and supervision, and to figure out how to, talking points and how to combat that stigma as it arises within the respective houses. This is about supporting staff and residents leaders to be able to just feel empowered and confident to take on these topics when they come up, because as we're talking about, this is going to come up. And also, even if we have a great set of policy and procedures and, folks are all trained, there's always turnover, right? And the staff or residents that will be in the facility. So it might just need to be, again, it's like continual quality improvement and then re-examining your policy and procedures over time. And, we're going to learn things from the different experiences that happen. And should we update our policy and procedures based on the experiences that we're having in the house? So again, this is maybe a more generic call to action. But then even something as simple as, I know Brianna from Walker put in the chat, right, that the quality standards of Walker say that these medications have to be allowed to be taken by individuals who will be going to your facility. Do you have something specifically in your policy and procedures that flat out says that? You'd be surprised at how many places sometimes find out, oh, we accidentally never put a thing that just says that straight up in our policy and procedures. If we have, Lauren and I talked with a different type of a provider the other day they hadn't updated their website in 4 years, and they are accepting patients now, but someone actually reported them because it was still saying they don't accept patients on methadone, and the reality was they are, and it's just they forgot to update their documentation and their website. So those would be a couple of things we will just really encourage people to look at and steps you can take ahead of time. And we can go to the next slide. And at this point too, we are going to open it up to know we can have some open discussion around types of policy and procedures. So we wanted to give an example of some materials. So there's lots of resources out there, especially if you're Googling right, MOUD and like recovery residences. So one resource we want to highlight is SAMHSA. So it's the Federal Substance and Mental Health Services Administration. They have actually published a couple different guidelines around also MOUDs in recovery residences, and they have examples of technical assistance information that's really helpful. So this one that we're showing is pulled right from their guidance document, and this talks about an example of what a recovery residence can do if they're trying to look at policy and procedures to reduce risk of diversion of medication. Right? So as we talked about, most patients who are coming in taking these medications are taking the medications to manage their symptoms, right? They're not going to be diverting it. That's an example of stigma and bias to think everyone who comes in is going to divert the medication. But there might be diversion from some people. Like that is something that may possibly still come up. But, different recovery homes could do different things to help mitigate that concern. If you have policy and procedures already in place to say, hey, when someone's coming in, do we want to encourage the folks to keep their medication stored in a medication lockbox or locking medication bag? If someone comes in without that, do we know resources out there to help them to get that? Does our recovery residence have every recovery residence is different, right? There's might be different level of staffing support that is able to be offered. Is it something where the patient will be keeping that locking medication bag in their own room with them? Is it something where the organization can have like a medication locking cabinet where it can be, stored on behalf of the individual with their consent to help make sure it's being kept up? Again, SAMHSA is talking about ensuring that residents and staff are properly trained on things like medication policy and procedures. Would you ever need to do, in certain instances, things like medication counts with residents and staff present? That's another diversion control procedure if there's concerns. And if talks about making sure, right, documentation and communication you have maybe with both the recovery house staff and the patient's treatment team are following all patient confidentiality requirements that like 42 CFR Part 2 and HIPAA, because there's some other things. Say a patient comes in to your recovery residence and maybe they've just started on these medications. And it seems like they're taking their medications appropriately as prescribed, but it seems like it's impacting them a bit. Like maybe, even they might be sedated. That is something that can happen when people are just starting out, when the medication is trying to transition. But we want to acknowledge that could bring up lots of feelings and even be triggering to like other residents in the home. But instead of having a policy to say like, well, we'll try and not have these people here. Is it something where we could encourage the patient to communicate with their treatment provider? Does their medication amount need to be adjusted? Could they take their medication in split doses? So taking one half earlier in the day and then the second half later in the day, so they still can manage their symptoms, but then control for other things, maybe like unanticipated things with sedation. Are there conversations we can have with staff about if a patient is experiencing things, are we treating it as we would any other medical condition? Like if someone was taking too much insulin or something like that, and it was making them sick and making them act out of it, we wouldn't say like, oh, we're going to kick this person out. We would say this person needs to go back to their doctor immediately to get things fixed, and we need to give them a period of time to have their medication be adjusted. So that's another thing. Providing proper documentation, facilitating open discussions. We talked about before, stigma and bias and misunderstanding sometimes just thrives in scenarios where we're afraid to talk about things. So having that passive education material out in the open, making sure the staff and residents leadership feel comfortable and confident in talking with all different types of residents about this, talking about it in groups, acknowledging that certain things might be triggering, and again, different ways to mitigate it. And then also there's other things. If there are concerns for specifically diversion, those opiate treatment programs or methadone clinics that Lauren was talking about, there is, they can theoretically daily dose a person where there wouldn't be medications in the facility, in the recovery house, because the patient is having to go to the methadone clinic to get their medication every day. There's also for buprenorphine, like injectable formulations of buprenorphine, like Sublocade, that actually, again, are injected into your body and that are there for 28 days. And there isn't even like a physical medication that you're having to take every day. That can be another element, both for diversion, but then privacy. If, folks want more privacy around the medications that they're taking, talking with them about talking with their provider about if injectable formulations of buprenorphine might be a better fit. Because then again, people wouldn't necessarily even know you're taking a medication. So this is just one example of one topic. But as you can see here, it kind of breaks out into lots of different considerations. And, we really just want to encourage you to think about what are the scenarios that are most likely to come up that would cause questions or concerns, and create policy and procedures. And again, there's lots of resources out there to help you do this. And again, our team would be there to help brainstorm with you on free technical assistance calls. But then I am going to pause there because I know I've been saying an awful lot, and I'm just curious, not to put anyone on the spot, but are there, as you're hearing this call to action, are you thinking about, are there areas of your policy and procedures you're thinking like, wow, maybe we don't have something about this? Anyone be willing to come off mute or put something in the chat about just what you're thinking about? If there might be specific elements of your policy and procedures you need to update.
Hi, my name's Tasia, and I work at the Salvation Army shelter. And so we definitely have a lot of clients that are opioid users. And one of the things that us case managers notice that we don't have is like, there are so many people on it, but we don't have anybody that's like guiding groups or just having enough resources to give them, because I think some of them do want to get off of it eventually, but they don't have enough like reassurance and just like maybe even awareness on different programs they can join. And so I was like wondering if you guys do like workshops or something like that.
I think we are open to partnering with really any organization that might want to learn more about things. So we could absolutely connect offline if you think there might be opportunities, or again, to brainstorm different resources maybe you could bring back. But you're right. I think even going back, someone else in this call, I think earlier had asked about what could we do if there are peers, case managers. Another thing would be, I know, right, the workforce is so hard right now, but also as there are more people going onto these medications because they are so effective, might want to think about trying to hire some kind of a peer or someone maybe even who has experience with taking these medications themselves. That could be really, really effective for the population. And then we absolutely do have resources around how to connect with treatment providers, connecting with local treatment providers who offer these medications. They also may be willing sometimes to send staff to just talk about these medications with your own facility staff. And I feel like there was something else I was gonna say, and I apologize. It's I left my mind at the moment, but I also see Nicole has come back on camera. I don't know, Nicole, if you have follow-up thoughts.
Yeah, I just wanted to say I work with Peer Olympia as the peer support specialist for coaching. So primarily what I do is I match recoveries with recovery coaches. And like I mentioned before, their journey is their own recovery. It's different for everyone, so it's very specialized for that individual. And when you had mentioned like support, I just wanted to say that's one mean of support, finding a recovery coach, so that they can help navigate kind of what that looks like if they're looking at wanting to get on some type of medication to help with their recovery or get off of it or whatever that may look like.
Definitely.
Thank you for sharing that.
Yeah, does anyone, this is, this can also be great for peer-to-peer learning. So just like Nicole just did anyone have any thoughts you'd want to share as well about other ideas that you've used in your houses that you think has been really helpful?
I do have one more thing I want to share. I think just, I don't want to say normalizing it, but almost normalizing it, making it so that the information is out there. A lot of the time I try to, why I attend things like this so that I can gain the information and kind of share it with my coaches so that it's out in the community. But I think normalizing it in a way that's like not scary, and it makes it to where like, hey, there's more than just one option. There's more than just one way, and making it to where those stigmas are kind of, I guess, not there anymore. I think what we do, I do a lot of different support groups to kind of help kind of just navigate through that with the coaches that I have. But at the same time, we have different resources here too at Paralympiad for our population that comes in, so that they can kind of see what options they may have.
I also just want to say that really, is so wonderful because it empowers the patient themselves, right? And that's really, the knowledge, the availability, the normalization of MOUD really helps to empower that person to make the best decision they can for themselves in that moment for their own, personal recovery journey. So I want to say thank you for doing all of that work. That's so important.
Thank you.
And also, I know Tasia had mentioned a few minutes ago about, sometimes patients also having a hard time navigating their own personal discussions around how long they should be on a medication. And I think this goes back to the one flyer Lauren shared with some of those myths and stigma. So again, it really should be an individual decision, and no one should feel a rush to necessarily stop taking these medications as soon as possible. I think a lot of folks oftentimes feel shame thinking like, oh, if I take this medication, is it like a crutch for me? Am I really in recovery? But the reality is, again, these medications are considered the first line approach to treating folks. And methadone and buprenorphine have been out now and available for decades. Methadone for like 60, 70 years in the country. So they're well studied. And what we've actually found, all the studies have shown that as long as someone is getting a benefit from them and not experiencing like withdrawal symptoms or cravings, there is in many ways like actually no reason for someone to even stop taking it unless they really choose to do it themselves. But again, I think patients oftentimes put a lot of pressure on themselves because again, it's hard to think, right? Sometimes that we might have a health condition where we might have to take a medication for some people, long periods of time or even the rest of your life. But then again, just going back to normalizing it, like again, some of these other analogies, some people have to take medication to treat their COPD or like their heart disease or their diabetes forever. Some people don't, but then like we're not judging someone because they might need to take insulin for a long period of time. But we do, I think self-stigma, right, is something that's so powerful, and shame is already so ingrained in so many people's journey of yeah, the struggles they have with their own recovery. So helping as much as we can to be that external force to just free them from that shame and then really encourage them to have those discussions with their doctor. And again, why do they want to stop? Do they want to stop because a loved one is telling them that they should stop? Or do they really want to stop because they're interested in stopping? And if they are going to stop, could they come up with a plan to stop very slowly with the help of a doctor? So if things aren't going well, there's also no shame for them starting on a medication or going back up on it again. So I'm really glad you brought that up, because I do think that's a big question that will come up for folks in recovery homes.
Thank you so much for that. It's really helpful to like just even have these kinds of conversations because we have programs and stuff, but it is like client based, so they're not like shoving it down people's throats, but also like I think if it was more openly talked about, people would take advantage of it more. But yeah.
Definitely. As we're thinking about this overall question I have to everyone about different policy and procedures, also, the next slide will kind of just give everyone a couple different ideas. So again, we really do just want to reinforce though, when reviewing these internal policy and procedures, we're not just doing this because again, it is what is the right thing to do for the patient. There's also legal risks. You could risk losing the financial resources sometimes that supports your house if there's state or federal funding. You could potentially open yourself up as an organization to legal action from even like, again, the Attorney General's office, the Department of Justice, the state and federal laws for disability. The ADA and WLAD do protect people who take medications and even medications specifically for opiate use disorder. And again, you have to provide reasonable accommodations for folks. So that means allowing people to, if you would allow folks to hold medications for other conditions in the house, you have to allow them to hold medications for this condition in your home. If you allow help with folks getting access to leave the house and go to treatment facilities for other things, it's reasonable to say you'd have to do it also for this. And then again, hopefully it never gets down to this, but again, these are requirements. And ultimately, if there are concerns with staffing, residence leaders, even residents within the home, some residents might be giving a hard time to other residents who are on these medications. At some point, someone will have to have a conversation with them to say like, hey, it's against the law to treat this person differently. And again, this is not what we have in the culture of this house. So just being really clear about that and feeling confident to know that these rules and laws do cover these situations, so you can talk about them and reference them with some authority. You can go to the next slide. Oh yeah, and this is again just more things. Again, your policy and procedures should allow for access where someone could take the medication to treat opiate use disorder of their choice. You do not necessarily require someone to stop as a condition of them coming or making them change the amount of medication that they're taking as a condition of coming. And again, those reasonable accommodations. You can go to the next slide. And again, we just wanted to include some ideas about different topics to look at in your policy and procedures. Like again, do you have a policy and procedure on how you'd safely store and inventory medications? And again, that can look different from house to house, and that's okay. this list here isn't necessarily telling you here's a black and white way of you have to do this, but you should have a policy and procedure that speaks to this type of topics. Are there specific state rules in this topic that recovery residents have to follow? Again, what do you do within your own policy and procedures? Are you treating like methadone and buprenorphine products differently? Do you need to be treating them differently? The answer there is probably no. If you have a policy and procedure for buprenorphine, chances are most of it is still applicable to everything with methadone. Same thing. What about mental health medications? Do you even address that in your policy and procedures? We're talking a lot about MOUD meds today, but there might be other medications for mental health conditions that you might realize like, oh, hey, we don't really necessarily have policy and procedures and trainings around that. Again, do you allow a resident to hold on to their own medication in a lockbox or a locking medication bag, or again, provide a place within the home for that medication to be contained safely? Again, do you have policy and procedures for other types of medication that you can apply to these medications now, if it makes sense? And then also an often question we get is, what do you do if someone unexpectedly moves out and they leave behind their medication? So I will address that one real quickly. We'll put a link in the chat. Take Back Your Meds is a Washington website. There are safe medication drug take back sites, and you could drop off at those take back sites, which sometimes are at like city halls or police departments or pharmacies. You can drop off these medications. You don't have to necessarily keep them on site, which can be, a risk or a stressor for a lot of people. So there are resources out there, but again, do you have a policy and procedure in place to cover that topic? Maybe not. So if something comes up, what will your staff do? So we just want to encourage everyone to be thoughtful, try again, and have a policy and procedure before you find yourself in a scenario. And again, to encourage you that there are resources out there like ourselves, our colleagues at the Division of Behavioral Health and Recovery, and Walker. We're all here to help you. And then we're going to show our contact information on the next slide. And there's also an email in there. It looks like the color kind of changed a bit, but phone and email. But also I'll see if Lauren has any closing thoughts before we can kind of just open it up for a little bit more discussion before we end today.
Yeah, I just really want to say thank you. And I know that there was a comment in the chat. So Kirsten, yes, this presentation will be emailed, so we will get that to Brianna, and she will send it along. But I wanted to note the comment in the chat that you made, and feel free, to come off mute and explain further. But the policy update we need is that residents can't ask or talk about any medications that someone else is taking. I don't know if you want to elaborate on that or talk about that a little bit more.
Well, I don't know how much I necessarily want to say, but we are, we just became Walker accredited, and it was a recovery residence prior that was a private recovery residence, very old school, been around for a long time. So a lot of different viewpoints on medication for opioid use disorder. And so it's about educating and training and letting people know that, people's medical information is their private information. You can't talk about it. You can't ask about it. You can't. So it's going to be a process, just educating. And I like the idea about bringing it up a group and talking about patient privacy. And it's not, and I don't know that it's happening now, but I do know there's some NA Nazis there that are like, oh, those weak, they're on Suboxone, blah, blah, blah. It's, it's lack of education. And I see primarily my own personal experience, the people that talk the loudest about it are people that have never had an opioid use disorder. So my comment is always, oh, have you been addicted to opiates? And they'll say no. And I say, you don't have any right to talk about this topic then. That's my personal, I'm not talking about professional, I'm talking about personal. That's what I say to them.
Well,
I have no idea what it's like.
And I think, you know, when you're talking about that policy and procedure place too, it doesn't have to be a black or white, like you can never talk about it, you must talk about it. You're right. Because I think there's a big difference between talking about it in group generically as a topic versus being
For
like,
sure.
hey, John Doe, you over there, you take methadone. What do you think about like this and the fact that you take it? So, right, I think
Totally.
that right to privacy is something that is still important for folks in the residence. But you're right, when everyone is living in the same home, even at the best of intentions, right? That privacy, it's a hard setting sometimes to maintain that privacy. So trying to find ways where it is appropriate to discuss things openly, but then also times when it's right for if a resident doesn't want to talk about the fact that they're taking medication, they shouldn't have to, right? Obviously publicly. So it is hard. But then you're right. I guess it's going back to what would you tell a new staff member if they came in and said, how should we navigate these conversations, right?
Mhm.
And you're right. I just want to highlight what you're saying. Like, we are in this time period of culture change, really, in all kinds of facilities in healthcare. And these medications haven't always been as widely used. But as the opiate epidemic has just grown and grown, and the fentanyl crisis is so severe, these medications really, again, are helping a lot of people. And there's going to probably be even more and more patients who will be offered these medications in the future.
For sure. For sure.
Any other thoughts or observation or experiences anyone wants to share, how they've kind of experienced things like this in their own recovery homes at this time? I see Lauren has put our contact information in the chat. Again, this presentation, I believe, has been recorded and is going to be sent out and on the Walker website, and we're going to send out our slides. So please, please, please don't hesitate to reach out to us if you feel like it'd be helpful for us to have side meetings to just, talk about things, problem solve with you all. Thank you again so much for letting us present today, and we'll turn it back over to Brianna and Walker. All right, guess maybe Sarah, if you're.
Yeah, thank you everyone for joining us. Thank you, Jessica. Thank you, Lauren, and thank you everyone for being here. Yeah, feel free to, take down the emails in the chat, and we will end today, and we appreciate everyone's time. So thank you very much for being here.
Everybody. Bye.